Hotbed Talk.
Welcome back, everybody. It gives me great pleasure to introduce this, the first of two sessions that the POETTS Society is running jointly in collaboration with the International Rehabilitation Society. The first of which, in this session, we're going to be looking at the impact of nutrition on perioperative outcomes and how it may be optimized in the perioperative period. It gives me great pleasure to introduce my co-chair, Gerrit Slooter, who is a colorectal surgeon from Eindhoven in the Netherlands and has a long-term interest in prehabilitation, having led the recently completed International Prehabilitation Study, which we hope to hear more of the results about later in this year. He established, along with Professor Franco Carli, the World Prehabilitation Conference and led one of those in Eindhoven back in 2018, and then co-led a conference with us in London in 2019. POETTS and the International Prehabilitation Society clearly work very closely together and are planning to merge together to lead the next World Conference on Prehabilitation next Easter. So with no further ado, welcome, Gerrit.
Thank you for the introduction. I'm happy to introduce my fellow countryman, Stephen Olde Damink. He's a professor of HPV surgery in Maastricht and in London. He does a lot of clinical and preclinical research, especially on cellular metabolism and nutrition. And he's very much internationally involved. And if you get a view of him later, you see he's also a father. He has 6 children behind him in the screen. So I would like to ask Stephen, welcome aboard, and what it has to do with nutrition and sarcopenia. And could you give a short introduction on sarcopenia and its impact on outcome?
Yes, I'm a surgeon, and as surgeons, we are very holistic because we treat the patient and we need to inflict trauma to these patients. So that's the reason that I'm very interested in looking at the metabolic interaction between the tumor and the host. So not specifically to nutrition, because that's one of the things that you could do, like exercise or nutrition or all kinds of other things that we do to kill the tumor. But my special interest is, so what happens with the patient when there's a tumor on board? And next to being a surgeon, I'm also an exercise physiologist. That's a study that I did in parallel in Maastricht, so next to do my medical school. So the things that I'm at the moment doing is kind of exercise physiology, but then for the patient. So I really look at the frail ones. What is interesting to me is the things we can measure before we do the intervention and how we can objectify them and take it into account to predict or to use it for the shared decision making. And the things that, I like to coin them as PRIMs. I still need to write a paper, but to me, these are patient-recorded initial measurements. So what are the initial measurements that are very objective, so not confounded by the patients or the history taking that we do, and we can use for our decision making. So the thing that I really like is to look at body composition, and the body composition on a way that is very easy for us, because most of our patients have an abdominal CT scans or even more than one. And what you can do is on the lumbar third level, you can do a slice and then calculate with advanced technology, and now also automated, so it's only a few milliseconds. You can really use it in your outpatient clinic to look at body compositions. And from the body composition data on L3, you can estimate the complete body composition of that patient and group them in variables that are aligned with muscle mass, but also muscle quality, the ectopic fat deposition in the muscle and myosteatosis. But the same is also true for fat. So where's the fat? Is it abdominal fat or subcutaneous fat? And what you can see there is that the interaction of the tumor to the host, so using the CT scans before the operation, already predict the outcome of the patient. So if you look, for instance, in pancreatic cancer, then the CT scan that I take just before I do the operation, the ectopic fat deposition in the muscle, so the myosteatosis, is as predictive in outcome, both long-term survival and disease-free survival of that patient when you compare it to tumor variables like the TNM score. In colorectal cancer or colorectal mets, also entities that I studied, you see that the speed, probably the speed of cachexia, so the speed that people lose weight, that is a hypothesis, is important. So a single CT scan in a colorectal met patient or a primary colorectal one does not give me information about the myosteatosis. So the relation of myosteatosis with outcome is not that clear. But if you take a delta, and so most of your time you've got an intervention, neoadjuvant treatment. So if you have 2 CT scans before you do the operation and look at the changes in these CT scans, you can see that ectopic fat deposition, so the arising of myosteatosis, does have a predictive outcome. And then when you look at the complete host, muscle mass or muscle quality is just one of the few things. You can also look at first host phenotypes. For in one study, I looked at patients that underwent a liver resection for colorectal liver mets, and we just identified 3 at first host phenotypes. One was poor muscle mass. You use a Z-score, so you have people that have relatively lower muscle mass. You can look at adipose tissue, subcutaneous visceral fat, so lower visible fat, and then a slight increase in CRP or a readout of inflammation. If you then consider these 3 host phenotypes, then the people that have all 3 of them at first host phenotype, they do so poorly that the prediction of only these 3 before I do the operation is better than the prediction of the commonly used FONG score, in which you also have comorbidity but also tumor characteristics. And it predicts both the outcome and disease-free survival.
Sorry to interrupt you there, but just to ask a couple of direct questions about that. So within sarcopenia, there's obviously the mass of the muscle, and as you've just been alluding to, the quality of the muscle.
So the more and more I look at the data that I use, I think you need to think about which tumor entity. So what kind of tumor is it? Is it a very cachectic tumor, which probably relates to the speed that people lose weight? For instance, if I do my outpatient clinic and I see patients with pancreatic cancer, they can have lost, 1 stone in a week or 2. And so 6 kilograms in 2 weeks' time. That's not uncommon. You seldomly see that in colorectal cancer. And you can even see cancer cachexia in breast cancer patients, but it's very subtle. So I think that and then if I look at all the data that I gathered, is that the L3 mass, so the muscle mass per se, might be more related to the body status of that patient than to the related to the quality. So one of the studies we did together and also with Malcolm West is that we looked at the CPET that was taken in a large cohort of UK patients and correlated that to body composition features. And there you can see the ectopic fat deposition, so myosteatosis, is related to function. So the CPET really correlated with myosteatosis.
A simple question. I tend to prepare my patients for surgery, a 4-week period with a multimodal approach and high-intensity training. In a period of 4 weeks, would you be able to see changes on a CT scan, or is the period too short to notice anything on a CT scan?
No, I think we need to test that, but I think we could. So the interesting bit about the prehabilitation is there's also a failure to prehabilitate. And together with our colleague Joost Klaassen in Groningen, who's also a professor in perioperative optimization. So he did 2 randomized control studies, and he found a particular subtype of patients that had a failure to prehabilitate. And that's quite a number, 20-30% of the total cohort. So for me, the interesting bit would be, who are these patients? If you look at the definition of cancer cachexia, which means you're losing weight, and you're not able to block the loss, so to get these patients anabolic by means of giving them nutrition. That's the definition. And maybe the same is true in some of our patients. So the interaction tumor-host might for some of our patients be in a way that maybe these are the patients that you would be able to treat with surgery first before the prehabilitation. But that's too early days. So we're now digging into the data of the 2 randomized controlled trials, although they're small numbers, to see who are the ones that fail. And can we make an analogy to cancer cachexia in which the patients fail for personalized dietician control, or you can't reverse cancer cachexia by just giving them nutrition. What we were unable to do up to now, because up to now you got a CT scan and then one of your PhD students, yourself, had to annotate these slides. It took 15 minutes, 20 minutes. It's now annotated. There are quite some annotations around. In my own group, with some big data scientists, we made an automatic L3 annotation. So these are, I think, tools that could help us as a clinician, because if you have the abdominal CT scan, then immediately we can ask for the body composition.
So at the moment, those tools aren't readily clinically available, certainly in the UK. So you have to analyse the CTs individually, which, I mean, hopefully that will be soon available, because it would be useful to have that with any abdominal CT report as a monitor of nutritional status or functional status.
Yeah, and I think it's important to consider that for everything we do. And so for any intervention, because most of our patients will receive neoadjuvant chemotherapy nowadays. The first, we do it already in colorectal, we do it already in esophageal, pancreatic cancer. So the PreOPTIMIZE-2 showed that neoadjuvant chemotherapy. And we all know that muscle mass and chemotherapy toxicity is related, and muscle quality is related. And the way we subscribe chemotherapy is based on, body circumference area. We don't, tailorize chemo based on body composition. So I think it will be very important to include these tools into the daily practice. It should actually maybe be part of our MDT, that you have more of these prims. So what are, what's the background, what's comorbidity, and what's the body state?
Absolutely. I would strongly agree with you that staging the patient whilst you're staging the disease and evaluating the host is as important for the response to both neoadjuvant treatments and potentially for their surgical risks and what you can optimize or not.
It can be very easy. So we looked at patients that had ovarian cancer, and we just had two moments. So we had the initial OR, laparoscopy. Then we followed them with neoadjuvant chemotherapy for the debulking one. And the women that were able to maintain muscle mass, they did, so much better postoperatively, but also survival independent of tumor states. So what happened in the period before we do the operation, and we treat them, not pre-rehabilitate them, but we, inflict damage to them by giving chemotherapy. So the women that maintained muscle mass, they had a better long-term survival than the ones that lost muscle mass, but it was independent of tumor characteristics.
Thank you. I think it's a good moment now to bring in another of our speakers, Dilly Lobo. Perhaps, Dileep, to talk a little bit more about using other tools to identify the patient that's at nutritional risk. And Gerrit was going to introduce some of your background.
You're looking now at Dilly Lobo. He's also an HPB surgeon. We're in the majority now. He works as at Queen's Medical Center at Nottingham. He is an expert because he has won prestigious prizes in nutrition and metabolism. And he's editor of almost any journal on clinical nutrition. So be aware, if you want to have your paper published, be nice to him or ask a bright question. What I like, I saw your pre-recorded talk, and I liked a lot that we are not talking about waiting list anymore, but we're talking about preparation list or optimization list, especially in times of COVID. And I have quite a simple question. As a surgeon, I think I'm quite capable of making a judgment of frailty of a patient patients once they come into our outpatient clinic room. Or do I need tools to really detect frailty?
Thanks, Gerrit, for the very kind introduction. And I'm not an expert in frailty, but I think most surgeons can recognize frailty by the eyeball test. When a patient walks into your clinic room, you can see the patient straight away, whether they're wasted, whether they can walk without support, or if they've come in a wheelchair. And I think that's really important because frailty is a sort of multifactorial condition as opposed to malnutrition. So what we've got to remember is that surgery is a catabolic condition, and the metabolic response to surgery is very much the same as that to major trauma. And when David Cuthbertson and Francis Moore described the metabolic response, they divided it into the ebb phase, which lasts usually for a few hours, where there's a decrease in metabolic rate. And then we have the flow phase, which is associated with an increase in metabolic rate and increased protein catabolism, mainly in the form of protein breakdown. And then finally, when the patient recovers, we go into the anabolic phase where they start rebuilding the protein that they lost. Now, teleologically, the metabolic response to trauma is a protective response because we try and raise our blood glucose concentration to maintain substrates available for oxidation. We try and hold on to salt and water to maintain the intravascular volume. But if this response goes on unchecked, it ultimately results in the demise of the host. And with systemic inflammation in the surgical patient, We know that protein catabolism results in a decrease in lean body mass and wastage of protein stores. The magnitude of the systemic inflammatory response syndrome corresponds to the degree of trauma, and the C-reactive protein is quite a useful test to see how inflamed the patient is. And if we modulate this response by multimodal interventions, we are likely to improve outcome. Now, weight loss is probably the most important sign of malnutrition, and we often ignore this. And this was recognized as early as the 1930s, when studies showed that if patients presented with perforated duodenal ulcers, they were 10 times more likely to die if they had lost more than 20% of body weight than if they had lost less than 20% of body weight. And what study remarked is that surgeons recognize this, but they don't really intervene to sort of reduce the further catabolism and further weight loss and loss of muscle stores. Now, Paul Wischmeyer has got some very interesting data from the US, which shows that 2 out of 3 patients coming in for gastrointestinal surgery has some form of malnutrition. And if a patient is malnourished, it increases the risks of postoperative complications by about 3 times, and these patients are 5 times more likely to die than the well-nourished ones. However, even in the US, where they spend a lot of money on healthcare, only 1 in 5 patients has a formal nutritional screening for malnutrition. And although 3 out of 4 surgeons believe that perioperative nutrition will reduce complications, very few actually implement this. And they found that it makes sense economically as well, because for every dollar spent on nutritional care in a hospitalized patient, the hospital system saves around $50. In spite of this, only 1 out of 5 patients in the US receives any form of nutritional intervention. And this is quite disturbing. In Europe, again, the numbers are very similar. If you look at all hospital admissions, the number of malnourished patients is around 25 to 30%, and in surgical wards, it's probably higher. Now, this is compounded by the fact that a lot of food that's offered to patients in hospital is wasted. And Simon Allison in Nottingham did a study many years ago, and he found that 40% of the food that was served to patients was sent back. And patients don't like to eat in hospital because they believe that the poor appetite is to be expected and that the appetite will return to normal once they go home. They have gastrointestinal symptoms that may preclude eating. And what we don't realize is a lot of them are inactive. They may be depressed or have a low mood and lack the motivation to eat. And again, a lot of medical healthcare professionals and patients believe that the most important part of their stay in the hospital is treatment and not eating. And so they go on to lose further amounts of protein and muscle mass. So I think this is a global problem. And for those of us who are surgeons, we need to realize that surgery is the 3rd most common cause of death globally. About 4 million patients die each year within 30 days of an operation. And a lot of them have complications which are associated with an increase in healthcare costs, long-term morbidity, and a reduced quality of life. So what we need to look at when we are dealing with patients who come in for surgery are both short-term and long-term outcomes. And most of us are familiar with the short-term outcomes, which include 30-day morbidity and mortality, and days alive at home up to 30 days after surgery. However, now, most healthcare systems are more concerned with the long-term outcomes, which include long-term survival, functional recovery of the patient, and they need to get back to the state of health they were before the operation, or even to a better state of health. And we know that a lot of our patients don't even reach 50% of the state of health that they were in before the operation. We need to have effective symptom control and improve the health-related quality of life. I'd pause here if you've got any questions for me. Otherwise, I'd continue and we could take the questions at the end.
Dileep, I think there's a couple of things to add, really. And my experience is really echoes the experience of the literature you've just presented, both from the States and Europe. And one of the things I think is very curious is there's a lot of data that nutrition leads to poor outcome. And actually, there's quite a lot of screening going on. But we seem unable to implement a standardized preoperative optimization pathway. Certainly, we're struggling to in the UK. So we've just surveyed, which will be published shortly, all the perioperative medicine services across the UK. So that's across surgical specialties. And 90% of people we surveyed thought it was very important. About half of them were actually screening, but that was usually just before surgery. So really when it was too late, so the week before. And then even if they did identify a patient at risk on MUST, only 20% of those surveyed had a structured pathway. And what I would say to Gerrit from his point at the beginning, I think we can all identify the very malnourished, skeletally cachectic cancer patients, and Stephen alluded to. I think the problem is there's a lot of silently hidden, at-risk malnutrition. So in our surgery school in Southampton, we screen, and 30% of patients are screened as at risk on the NRS. And of that 30%, only 12% of them were known to one of our dietitians at that point in their pathway. So my challenge would be, how do we get this better? What can we do? Because saying the same thing doesn't seem to be working. What are your thoughts, everybody, on that?
I think you really hit the nail on the head, and we need to sort of take a step backwards, and all healthcare systems need to realize that an initial investment leads to long-term cost savings. And if I had my way, there would be a dietitian present in every surgical clinic. And once the surgical consultant or registrar has seen the patient goes over to the dietitian. And the whole process starts in the clinic, because the patient develops the relationship with the doctor, the surgeon in the clinic, but we need to pick up the problems. And it's not just nutrition, it's other comorbidities. Diabetes is very rarely picked up in the clinic. GPs sometimes don't put it in the letter. The surgeons don't ask the patients if they have diabetes or not. And so we need to have this multimodal approach to the patient. And that little bit of investment to have an extra pair of hands in the clinic to look at the patient and identify those at risk would really help. And we know now that, even before COVID, we had reasonably long waiting lists for non-cancer patients. These waiting list times are going to increase. And, we've come up with this concept of converting these waiting lists into preoperative preparation lists. And it's a sort of, again, a multimodal intervention, because the patient needs to be part of the whole process. And that's the most important thing, because if the patient knows why we are doing these interventions, the patient will cooperate. There's no point telling explaining a few exercises to the patient and say, go home and, pick up a dumbbell 10 times or 20 times. The patient's not going to do it. So it needs to be supervised. And the patient needs to realize that from their point of view, if they invest in their own health, they are going to have a better outcome. And the same thing works for smoking, for alcohol. They also need to be psychologically prepared for the operation, and we need a buy-in from the relatives and carers as well.
We've had a question through Slido. One of the delegates has asked, how do we get buy-in from key stakeholders to invest in nutrition and dietetic services in perioperative care? Do you have any thoughts there?
If I knew the answer to that, I wouldn't have any complications. No, but I think, again, a lot of hospitals do have the budgets, but it's the question of making people realize that if you spend a certain amount of money, and there is a certain initial investment, you've got to employ extra dietitians. There may be more time spent by patients in the clinic, but that really leads to cost savings in the long run. And Paul Wischmeyer from his data has shown that for every dollar invested in nutritional care of the surgical patient, there's about a $50 saving. And that's a huge investment. It's better than buying shares. Apart from Bitcoin, you won't get a larger investment return. And so we've got to convince our managers and our stakeholders and commissioners that this is a really important part of surgical treatment.
Yeah, I think we have a window of opportunity, certainly at the moment in the UK, because of the extended waiting times, and there is focus and sometimes some guidance. There's just been a multi-college list of guidance that was published earlier this week, looking at how we should be preparing patients, with a main recommendation for centralised funding. So we'll keep our fingers crossed and watch this space. And as you said, it's about redistributing funding in the long term. But the problem is, in the short term, you need more dietitians preoperatively. In the long term, you may need less postoperatively. But there's a transition period where you need more people, and that's what everybody focuses on. Hopefully, Gerrit, you'll have some cost effectiveness data later this year from your study. Have you looked at the cost effectiveness of your multimodal prehab?
We have definitely looked at the cost effectiveness of a total multimodal pre-rehabilitation program, which is a supervised program, and you can really save a lot of money. But what I noticed most among all countries that we do research at, or the people you meet from other countries, that the circumstances in the countries are so different. We have physical therapists at the corner of every street. And for instance, in our pathways, oncological pathways in Holland, there's always nutritional screening and always an intervention on nutrition in these patients. So it's mandatory to do a check on that and to send the patient to a nutrition. I actually would love to ask a question to a nutritionist or a dietitian, and I don't know whether Chelsia is on board already.
Yeah, she's just arrived. So would you like to introduce her, Gerrit?
Yes, Chelsia is one of the nicest persons I've met over the last few years, and so modest. She is a clinical dietitianist and truly an expert in pre-operative optimization of patients' condition. She has just finished her PhD at McGill on pre-rehabilitation and all things like that. I would really love to ask you a question about optimization of patients, because Dileep already told us that about 25 to 30% of the patients is undernourished, and we take actions for that, and we try to optimize their condition and bring them back to about normal. But how about the 70% of the patients that is not recognized to be frail or undernourished? Would it help to support them in their nutrition as well? Because we actually would like to improve every patient's outcome and not only the frail ones.
Yeah, absolutely. We actually have a kind of like a surgery school, like Denny was talking about. So even from just a patient's point of view, patients want to know how they can optimize their nutrition because they believe that food is medicine. So even before surgery, they don't usually think about it all that much unless they've had surgery before. Patients who've had surgery before recognize that they need to kind of build up a reserve. They actually use that word, reserve, that they need to build this reserve. But in hospital, I've had so many patients say to me, I know that I need to eat, but I can't eat. So our surgery school kind of, what we do is we actually explain before surgery how you need to eat, in hospital how you need to eat, and when you go home how you need to eat. Because patients say things to me like, I didn't know I wouldn't be able to lift 10 pounds after surgery, because that's one of the restrictions in our hospital. And groceries weigh more than 10 pounds. So I would have gone out all my groceries and prepared meals ahead of time. So it's really a patient-centered objective to provide nutrition information to all patients, not only because they really do want to hear this information, but also because you can hopefully prevent perioperative malnutrition throughout the perioperative period.
And how about the people's knowledge on nutrition, but the people living around this hospital and being of the age that needs surgery, they tend to have terrible eating habits. They actually have a sedentary existence. They sit on the couch, watch Netflix. I don't know whether you have Netflix in Canada as well, but we watch Netflix and we start eating our chips or potatoes, and then once we are almost satisfied, we start eating all the protein. And how about that?
I'm sorry, what's your question? What are their eating habits like?
On the floor, you deal with these patients. What do you tell them? What kind of information do you give them on normalizing their eating habits?
So we focus on balanced eating, and I focus on either their plate or handfuls of food. So I talk about either you want half your plate to be vegetables or 2 handfuls of vegetables, and then you want to have a quarter of your plate to have protein or a handful of protein, and then a quarter of your plate to have grains, and choose whole grains, things like that. And then I also specify that with the protein, it should be about the size of your palm, because if you eat more than that, you're not necessarily using it to build muscle. If you eat less than that, it's a missed opportunity. And I usually ask them to eat their high protein foods first, because sometimes people, especially when you're sick, you get full very easily. So I say focus on eating those high protein foods first and then work around your plate.
Another question on rehabilitation. We suggest a multimodal rehabilitation, of which nutrition is one part, the supplementation of protein and vitamins. Which do you think is the most important factor within this multimodal approach?
I'm biased because I'm a dietitian, but I have to say that because I think they have to go together because they help each other, right? If you have patients who are exercising, then they're able to, it will enhance nutrient substrate utilization. So they have to go together. I do believe that. But that said, nutrition, you can optimize nutritional status in a very short window of opportunity before surgery. So for me, my primary goal is to optimize nutrition and use exercise as a supportive to assist with nutrition optimization. From my point of view, nutrition is the primary component and exercise supports it. But that said, there are also some patients who are completely nourished, they're well nourished, and they have poor functional capacity. So in that case, then the exercise person has to optimize them, and nutrition might be supported in that. So it really is based on a personalized risk stratification. You can't, my bias says go for nutrition, but then when I think about it, you do really have to risk stratify patients and give them the personalized intervention that they actually need.
Whilst talking about that, we had a question from one of the delegates about screening tools, particularly for the frail obese patient who's sarcopenic. Do you have any thoughts about how you can identify those patients?
To identify malnutrition in those patients.
Yeah, working out which obese patient is sarcopenic or not, essentially, or frail, or malnourished despite being obese. And people talk a lot about sarcopenic obesity, the malnourished obese patient, but all the screening tools, as we've alluded to, talk about weight loss and cachexia, and those two don't always go hand in hand. So I think clinicians are wondering how you identify which in the mass of obese patients are the ones that you should be most worried about. Do you have any thoughts on what tools we can use? We've heard from Stephen about the CT analysis and body composition analysis. Do you have any other thoughts?
Yes, I think CT is definitely one of the gold standard options. There's also a calf circumference, the SARC calf, you can use to identify, and there's an obesity correction there to identify sarcopenic patients. But I have to say, so you wouldn't be able to identify muscle just by asking about weight loss. But if you ask about weight loss, you will capture malnourished patients, no matter what their size is. You just have to be sensitive when you talk to patients about these questions, because I have found that many patients, they're very ashamed of malnutrition, and they don't know what will happen if they actually expose that they've lost weight before surgery, or if they're not eating well. So you have to, in those questions, you have to be really sensitive to why you're asking them and what will happen if they screen positive for malnutrition. So I think that's more of the issue, that we don't identify people sometimes because they don't want to give us the information. We have to really be careful there. But yes, you can use the SARC count. You can also use by muscle mass. We have bioelectrical impedance, for instance, as well. You could use bioelectrical impedance if you want to see muscle mass. So that's a pretty handy tool that only takes a minute to use. And then look at muscle quality as well. So you can have the patients do some functional tests, like a gait speed or 6-minute walk test, and see whether their muscle function is, if you can't actually assess muscle quantity.
There's quite a lot of questions on Slido about the quality of hospital food and the impact this has on patients' desire to eat. I don't know if this is a universal thing, but there's a lot of upset about cornflakes and jelly in the NHS and white bread. Do you have any input into the diet that your patients get, or is hospital food good in Holland? I know it's not good in the NHS largely.
I have done a whole qualitative study on this, actually, and I was very surprised. I used a really innovative technique where I had a patient interview the patient, and she only asked, "Tell me about your experience in hospital." And every single patient talked about food, unsolicited. So it's so important, the food in hospital, to the in-hospital experience. Almost nearly every patient felt that the food was bad, I have to say. But it's not just about the actual food. It's more about this kind of, what are your comfort foods? What time do you usually prefer to eat? And it's a mixture of emotional things and things like status even. So status is important in when you're eating and how you define yourself. I'm getting philosophical here, but food is more than just food and why people eat. It's very psychological as well. So in hospital, it's not just about the quality of the food. It's also about the whole environment. And sometimes, maybe you're okay with eating chicken and potatoes and that's what you got, but that's not your comfort food and you weren't feeling very well at that time. On top of that, so not just the psychological point, on top of that, we have patients who miss meals because they had a test, or they can't eat because they have someone beside them who now has an ostomy that's exploded, and now their appetite isn't there. So many barriers to eating well in hospital. One of the things that we do to counter that is actually just tell people, bring some food from home, because those are the comfort foods that you like. So just bring those foods in from home. And you know what? There's a fridge down the hall. So put foods in there that you like, or go get snacks if you missed a meal. There's Enter in there, or there's Boost or whatever. And there's also peanut butter and crackers. So we give them tips on how you can eat well in hospital. I've had so many people tell me I didn't know I was allowed to bring food into the hospital. So something so simple. And usually eat everything that someone else taught them.
Yeah, I was just going to say that eating is a social experience. And when I was a junior trainee, we used to have dining rooms on every ward, and patients would have to get out of bed and go and sit at a table and eat their food. And that doesn't happen anymore. The food is served at the bedside. And, before they've even finished eating, the plate's taken away. And some patients, even though they want to eat, they're slow eaters and they can't consume as much as they want to before the thing is taken away. So again, we need to think about that. And the advantage of the dining room was that, patients had to get out of bed and walk a little as well. And again, there was a common room to watch TV, and you didn't have TVs at the bedside. And all that has made patients more sedentary in hospital.
Yeah, I agree. Commenting on the wide variability in patients' response to cancer. So some patients, as you sort of alluded to earlier, get very sarcopenic and lose a lot of weight. Do you think that's related to host factors or tumor factors or a combination? There's a suggestion, do you think epigenetics has a role, or the patient's inflammatory response? I just wondered what your thoughts were, or anybody else can join in.
Well, there is a relation between the cathectic state, body composition, and inflammation. So I've got a whole line of research in which I make patient-derived organoids and then, grow these organoids and look at conditioned media to see if there are variables when you expose that conditioned media to ex vivo systems like smooth muscle cells or skeletal muscle cells or brown adipose tissue. So you see there a relationship or a difference in the cachectic potential of variables derived by these tumors, these mini tumors from patients. So there's certainly a tumor part of it. We know that cancer-associated fibroblasts that are very closely related to the tumor microenvironment, whether very close or a little bit, a few cells away from the tumor, play a certain role, of the MICAPs and the ICAPs. These are all related. And then, of course, factors that might be particularly, the topic for surgical patients. So interruption of your enterohepatic cycle in head of pancreas tumors or liver tumors that can block the bile acids flow and can stimulate bile acids. And bile acids, of course, trigger TGR5 on the brown adipose tissue. So maybe they activate the brown adipose tissue in which your thermostat is put a little bit higher. So it's multifactorial. You see the same problems in GI tract tumors and non-GI tract tumors, and like, for instance, not non-small cell lung tumors. So the idea is that it's certainly tumor host related. And I think that some of the variables that are produced by the tumor do inflict this inflammation state. And what the response is of that inflammation state. So for instance, if you look at myostethosis, so what's the reason that you have fat deposition in your muscle? Is it because there's increased lipogenesis, like you also see in the morbid obese, the patient that we operate for morbid obesity? You can see probably the same as sustained inflammation. bipolar stage, you see myostetiosis. Is that a similar phenomenon? Or are there, is a local stimulation of fat cells, like what you see in tumor host intakes? I do think it's both, but it's still a major topic for research.
There's another question here asking about how we engage with primary care, because clearly the time to first screen a patient for either malnutrition or other factors, as you mentioned, comorbidities, is probably the time when you refer them, rather than the time just before the operation, which it seems to be is when sometimes we get access to the patient. How do you think we could best integrate these services across primary and secondary care? Because the patients want things to be done near home, I have to say.
I think you're absolutely right. And one of the problems we've had in the UK is that with centralization of cancer care, a lot of things in the feeding hospitals or in the GP practices are not being done, because they think everything will be done in the centralized institute. So yes, the GPs need to recognize these things. And when we wrote the guidelines for diabetes, we made it very clear that in the referral letter, the GP has to mention whether the patient has diabetes, whether it's type 1 or type 2, and list the medications, and also probably put an HbA1c level. Similarly, we very rarely get patients referred to clinic with even a BMI recorded. And I think these are really important things that the GPs have to realize, that the whole process for surgical recovery starts at the time of referral. And if we optimize the patient right from the start, then we will get a much better outcome. So very often we are sort of shutting the stable door after the horse has bolted. And that is of no benefit to the patient. And again, they've shown that if you want to give preoperative nutrition to patients, you need to give it for at least 10 to 14 days. Giving it for a shorter period, that probably doesn't help. And similarly, giving nutrition for longer periods, unless the patient is really cachectic or malnourished, doesn't help. Similarly, with the pre-rehabilitation, there are some studies which have shown that if you are giving patients or putting patients on an exercise regimen, you need to keep them on that regimen for at least 4 to 6 weeks to have a positive effect. Now, the problem we have with cancer care is that if you delay the operation by 4 to 6 weeks, especially in patients with, say, pancreatic cancer, who need the operation as soon as possible, you're going to sort of maybe let the tumor grow in that period. So there are several things we've got to balance together. And neoadjuvant chemotherapy, in a way, is a good sign, because while the patient is being given chemotherapy, we can put them on all these rehabilitation regimens and optimize them when they come in for surgery.
Because a lot of people worry with prehab, particularly surgical colleagues have been concerned about delaying surgery to rehabilitate. But it's our experience, certainly, that when we actually mapped the pathway from when the GP refers a patient to when they get to the operating table, it is usually 4 to 6 weeks, even for cancers such as pancreatic cancer, because they're referred, and then there are loads of scans, and we spend ages, doing multiple scans and a biopsy, and we stage the tumor, and then we have these MDTs where no one talks about the patient attached to the tumor, largely. And often, if they're from a tertiary center, as you suggest, even more so, because we don't know the patient. It's not one of our own patients. It's come from externally. But, I often think that if we actually optimize them from the beginning, then we would get around the problem that we wouldn't have to delay surgery. But it's the fact that we're trying to do this only when we get to secondary care, which is too late.
If you can design your pathway, and everyone is involved in the care of these patients, you can start early doing a program like that. For instance, we start our pathway with a patient in colorectal care, a patient referred to the endoscopist. And as soon as the endoscopist sees a tumor or a large polyp in the bowel, he will do the whole workup within 3 days. But what he also does is tell the patient after the endoscopy that his treatment will start with optimizing his circumstances, and that in a few days he will be expected in the hospital with his training suits to be tested early. So that will help you. You do not need to delay your surgery more than a week, even in a program of 4 weeks of pre-rehabilitation. And besides, we know from literature that there is oncologically no urge to operate within a couple of weeks. Even with a delay of 8 weeks from diagnosis to treatment, there shouldn't be an oncological problem. And we did a literature search and checked all different countries around the globe and their rules, or at least their targets for treatment. And they're all different in every country. We realized in Denmark, every patient has to be operated within 2 weeks. So they had to ask for an exception to the law to be part of the pre-rehabilitation program, because the pre-rehabilitation program takes 4 weeks in a study. And we happened to publish this in the Lancet Oncology this year, that there is, all these guidelines are really contradictory, and we shouldn't be that much afraid of postponing or delaying surgery for a week, although every patient wants to be operated the next day. And that's my question to Stephen, is that there's a lot of factors of the tumor that might influence the host, and there's a lot said about body composition may potentially caused by that. But are these factors modifiable? Can you, although a tumor might interact with a host, can you still modify these factors and increase outcome?
I think by a therapy, so maybe by neoadjuvant chemotherapy or by removing the tumor. So this is what I alluded to, referring to the subgroup of patients in the prehabilitation program that fail to prehabilitate. So I can imagine that there are some patients that you can only improve if you resect or treat the tumor. That's just a hypothesis. That is in the brainstorm with Joost Klaassen, because he had quite a significant proportion of people that he enrolled in his randomized controlled trial for prehabilitation that failed to prehabilitate. And that is also what you see in cancer cachexia. So there are nice studies in cancer cachexia in which a patient receives personal dietary care and they still lose weight. So you can't modify or treat cancer cachexia. You can only treat that by operating the patient or give chemotherapy or radiotherapy that really kills the tumor. So there might be something also for prehabilitation.
Yeah.
Plus, it is important to identify, which ones are the ones that you can prehabilitate and which ones are not. So that is the core question, I think.
Yeah.
No, I'm just going to say that we don't pay attention to post-operative rehabilitation. And a lot of patients, when they go home, they just lie in bed and do very little. And I think that's equally important if they've got to build up the muscle mass that they've lost in the perioperative period. And we do need to concentrate on that and, improving their core strength so they get on and, recover their functional status.
First of all, I mentioned earlier the publication that was released this week about optimizing patients on waiting lists. Several people have asked that question. It's called Preoperative Assessment and Optimization for Adult Surgery, including consideration of COVID-19 and its implications. It is available readily on the Royal College of Surgeons website, the Centre for Perioperative Care, POETTS website, British Geriatric Society. So if you go to any of those websites, you can download that publication, which is a PDF. There's more questions that have been about the eating experience in hospital and how that could be improved. Any thoughts about having designated eating areas? I don't know, Chelsia, if you wanted to.
Yeah, I think that Dileep covered that really well. I think that it's a social environment that might help patients move as well as eat a little bit more. One of the things that I did miss, though, when I talked about that earlier, which is very important, is explaining the why. So if you have patients on a therapeutic diet, they need to understand why. Or they get white bread and they don't know why they're on a low fiber diet and they think that the hospital is just giving them unhealthy food.
Again, comments about overload in the UK of the primary care system and whether it's better for us to arrange this in pre-assessment clinic. Again, it depends on the structure of the pathway, but with cancer patients, the pathway is often too short and the pre-assessment may be too late in the pathway as well. The system may be slightly different with benign disease and benign operations. And there are some questions, and we've got quite a few surgeons on today's panel to ask this, about whether we should be prehabilitating patients before you even see them, which I personally think is a good idea. But what are your thoughts on that, Gerrit? Before you as the surgeon see them for their surgical disease, should prehabilitation started? Well,
we have a discussion whether you should prehabilitate only the frail or whether you should prehabilitate everyone and put everyone in a high-intensity training program. And if you believe in training everyone and pushing forward the curve of physical condition, you might as well start at referral or even earlier. The GP could play a role in that. And we have a high intensity program in our hospital, and we realize that these patients should not come to the hospital 3 times a week, but go to physical therapists in the area close to their homes. Even primary care could refer patients to those institutions to be optimized for we're not talking about surgery, but actually for any kind of treatment.
And probably the needs-based element of it as well, as we've alluded to earlier. Not everybody, patients who are reasonably fit, might be self-motivated and able to train effectively outside of a supervised program. Others, maybe not so much. Last question I think we can squeeze in before we just wrap up. Artificial intelligence, we've been asked. Do you think that could help in the pre-assessment and optimization of patients during prehabilitation? Anybody, any thoughts on that?
Yeah, what I called PRIMS, patient-recorded initial measurement. So you can think of all kinds of parts of the information that we get on the patients that needs to be integrated, and that's a lot of data. So you've got host variables, you've got CT variables, that can be CT radiomics, that can be body composition, that can be inflammation state, the functional test, there are all kinds of functional tests that you do. It can be static comorbidity assessment, it can be geriatric assessment. So if you would divide that, there are so many variables. For a longitudinal trial, just maybe registries European-wide to get more than 100,000 plus patients enrolled, then it would be valuable. But I can imagine that we're doing MDTs in which the patients will be presented to us in all kinds of domains in which we use these objective data.
I hope that will be the future. I want to thank all of your speakers for contributing today, because we need to bring the session to a close, sadly, because it's time for some lunch. But thank you very much for all your contributions, for what's been a very interesting session, I hope.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.